your job works right now. We know that currently you are working in the COVID positive services in the hospital. So could you tell us a little bit about that experience and kind of about the demographic that you're seeing there?
Sure, I'd love to. So I am a hospitalist, which means that I take care of patients who are admitted to the hospital. And the number of COVID-19 patients who are sick enough to require hospitalizations is a key indicator for understanding how severe the disease is and really where we are in the pandemic. Overall case numbers don't tell the full story. So about 10 days ago, the number of patients who were hospitalized across the UW medicine system essentially jumped overnight, and we opened up what's called our hot zone in multiple of our hospitals. So I work over at the University of Washington Northwest campus. The hot zone is an area of the hospital where we cohort and cluster COVID-19 patients together. And we have a variety of staff members that spend most of their day in that area taking care of these patients. What I found over the week is that most patients who I was taking care of were admitted to the hospital about 7 to 10 days after the onset of their symptoms. So many of them may have initially had mild symptoms that may have gotten better and then experienced a worsening about a week into their symptom course. And this was not just elderly patients that I was taking care of. I had multiple patients in their 30s all the way into their 90s. And as we see an increasing number of cases in a younger patient population, we're seeing younger people be hospitalized, which is a little bit different than what we were seeing initially in March and April. And then another, I think, key point is that while we read a lot about cases increasing and the number of cases, to me, they're not just cases, they are patients. It's very emotionally difficult to be hospitalized right now as a COVID-19 patient. They are isolated during their hospitalizations. It's very scary to be dealing with this novel pathogen. So just recognizing that this is a very unique experience. And it's also a very stressful time to be a healthcare worker, but we are doing everything we can to keep each other safe in the hospital. So that's my rundown from the last week.
Thank you so much for that. I think it's hard for those of us who aren't in there kind of seeing everything to get that idea. And so that perspective is super helpful. And then Dr. Cohen, your role is a little bit different, but can you tell us about what you've been doing in infection prevention and how that's been for you over the last few months?
Yeah, thanks, Abby. So hi, everyone. I'm Seth Cohen. I'm an infectious disease doc, and I'm a medical director for infection prevention across the University of Washington Medical Center. I also direct the COVID testing drive-through clinic at UW and help run employee health at the UW Medical Center. So I really split my time between those responsibilities and then caring for patients on the infectious disease service in the hospital, which includes COVID patients. And really both, Dr. Mani and I spend a lot of our time thinking about how to make the hospital safer for our patients. I'll say also that's my professional life. In my personal life, I have a first grader at home as well as a preschooler. And so I can completely relate to many of the people who ask questions about, how this virus impacts kids and a lot of the really vexing issues around childhood education. But both Dr. Mani and I have been in infection prevention, really since, before COVID started. And this year has just been a complete roller coaster, and it's hard to imagine that we have gotten to this point. We are facing yet another surge at UW Medicine. We're happy to talk a little bit more about that.
Great, thank you so much for that information. So I think we can kind of go into some of the questions that the audience had brought up prior to this. So let's talk a little bit about transmission and exposure and all of that. So we had a lot of questions about the incidence of COVID in Seattle, and Dr. Cohen, you spoke about that briefly, and some ideas of why maybe we think these cases are going up is what people were curious about. Can you tell us a little bit about that?
Yeah, so for those of you who don't know, there's a terrific dashboard for Seattle King County Public Health, and there's also a great dashboard for the Washington State Department of Health. And even actually the UW Husky testing program has a dashboard, so you can find more about cases across UW and on upper campus. The trends in Washington State and within Seattle are very concerning. As many of you know, we are at about 262 cases per 100,000 residents. And so that's high. The goal initially had been less than 25 cases per 100,000 residents. And this number just keeps going up. What used to look like a curve to me almost looks more like a climbing wall. It's just getting very, very steep. And we're seeing, record new cases daily. The percent positive, which is something that I pay a lot of attention to, I think is a good metric. So the percent positive for King County, is about 7%. And unfortunately, that to me suggests that there's also a lot of undercounting. There's what we get reported as official cases, but there are a lot of cases that we don't actually know about or don't come to public health attention. So the percent positive is likely higher than that. And across UW, within our own lab, our percent positive is about 8%. So very high, and I think that will continue to increase. South King County in particular is very hard hit, and deaths and hospitalizations, which we're all bracing for, are also, those are lagging indicators behind cases. And as Dr. Mani mentioned, from her work in the hot zone, we are already seeing an increase of people in the hospital. So unfortunately, it's a lot of young folks. It's the fact that people have moved inside during the winter. And there's something about the seasonality of COVID and respiratory viruses that we probably don't fully understand, but certainly leads to increasing transmission.
Thank you. And there was a quick question, just a clarification there. Is it 262 per 100,000 per day or overall?
Overall, that's the rate over the last week, I believe.
Thank you. And then a lot of folks had questions about this exposure and transmission. Dr. Mani, can you elaborate a little bit on how long you consider someone is contagious after an exposure as well as after being tested positive?
Sure. These are great questions because understanding the transmission and the duration of infectivity have big public health implications in our ability to control this pandemic. So after an exposure to COVID-19, most people develop symptoms around 4 to 5 days after their exposure. That's the incubation period. And about almost 100% of people, 98%, will develop symptoms by 12 days. Folks will usually test positive about 1 or 2 days prior to their symptom onset. And that's really the most infectious period, right before you develop symptoms and for the first few days after your symptom onset. From there, your infectivity declines. In patients with mild disease, we really don't think that they are contagious after about 10 days from symptom onset. So even if you have a lingering cough, some lingering symptoms, the virus is not transmissible at that point. This data is powerful because it helps us feel more confident in getting people back to work and back to their lives. And this is also an area of research that I think we've made a lot of progress in since the beginning of the pandemic, where it was not so clear how long people would be infectious for. The last thing I'll add is that many folks ask, do I need a negative test before I go back to work or I go back to my life? And the answer is probably not. Repeat testing with the PCR test is not really necessary in the 90-day period after your initial test. And that's because the PCR test is very sensitive and it will pick up dead virus and inactive pieces of the virus. It's not a really good marker of whether you are infectious. So we expect these tests to be positive for weeks and maybe even months after your initial positive test. So we go based off of your symptoms, 10 days from symptom onset.
Great. And then we talked about how long we think people are contagious and their likeliness to expose other people. Is there a time period, Dr. Cohen, in which someone tests positive that we feel that they will not be able to kind of get COVID again? Or is there a safe period after they've tested positive that we think that we've learned about?
So yes, we think so. I think this also embedded in that question are, questions about reinfection. So the data that I've seen regarding immune response is really quite encouraging, and we think that antibodies and other parts of your immune response are actually quite long-lived. To date, we've only had about 5 or so really credible reports of reinfection, and that's in the context of this really being the most surveilled virus in history. So it's really encouraging to me that these events seem so common. We do think that antibodies in general are probably protective. It's normal for antibody levels to wane a little bit after initial infection. I realize that gets a lot of media attention, but we don't tend to focus on those levels clinically. I would say as a rule of thumb, it's usually unlikely for somebody to be reinfected before 90 days. We're also, learning a lot more about this, and people, a lot of my patients want to get their antibody tests done. We can have false positive antibody tests. And so I just want to be really clear that even if you have a positive antibody, we don't want this to be a passport, for people to feel like they can engage in risky behavior. Don't act like it's your 21st birthday all over again just because you have a positive antibody. I would say that's at this point a misunderstanding of the science, but we do think that antibodies are protective at least for 90 days, if not longer.
Thank you so much. And I think that's really helpful to think about it in that way, because those questions have come up pretty frequently about antibodies and whether that means people are safe to kind of go about their business. And I think focusing on still having these safe practices is essential for all of us to know. Along the lines of this transmission and infectivity, we've heard a lot of words about quarantine, isolation, and so forth. And I think some of those definitions kind of get made interchangeably, and it's a little difficult to follow. So can we get some clarity around what that really means in regards to people who have tested positive or compared to those who have been exposed, and where essential services and kind of going out to do what you need plays a role and comes into play into those situations. Dr. Mani, do you think you could break that down for us?
Sure. So I do think that the terms quarantine and isolation are sometimes used interchangeably, and they're very similar terms, but I'm happy to break it down. So if you are infected with COVID-19, you should isolate at home until you are no longer infectious. If you are exposed to COVID-19, you should quarantine at home and monitor for the development of any symptoms. Or if you are quarantining and you're monitoring your symptoms before, for example, visiting a relative, that would also qualify as a quarantine. So the principle is similar. The more restrictive you can be in your quarantine, the more you can trust it. So there were some questions regarding, can you go to the grocery store when you're in quarantine? Can you go to a doctor's visit? And there are no real hard guidelines for this, and there's no real data. But again, I think it becomes more challenging to trust your quarantine if you are spending time outside of your home with others during that period. So I think the more restrictive, the better. We also know that family clusters are very common with this infection. So if someone in your household tests positive for COVID, that's a very high risk situation, and you should be adhering to a strict quarantine. And that's even if your test comes back and is negative. So you might have a family member in your house test positive. You may get a test tomorrow that's negative. That doesn't mean that you couldn't go on to develop infection in that 14-day period, which is why it's very important to quarantine regardless of your test in those high-risk situations.
Great. I hope that helps clarify some of these things for people. There is a question, this is actually a good segue into our safety topics, about children and the effect of transmission between them and to adults and their kind of hesitation and how they're doing with COVID clinically and what it looks like for them. Dr. Cohen, do you think you could answer that for us?
Yeah, sure. I'd be happy to talk about children. As I mentioned, I also have 2 young kids at home who are doing Zoom in my basement, so we think a lot about this. So children of all ages, and this includes babies, can get COVID, though thankfully, and I would say this is sort of one of the silver linings of COVID for me, is that kids less than 12 to 14 years of age seem to be less affected than adults. Most of them get it from household exposures. For whatever reason, transmission from children seems to be less common. I'm not exactly sure why that is, because their viral loads can be just as high. And as any parent knows, children are highly competent at spreading other respiratory infections like flu and even the common cold. It's really actually hard to imagine what life was like for parents during epidemics like polio, when everyone was terrified of a child suddenly developing paralysis. COVID, thankfully, is a little bit different. In schools and daycares, transmission does occur, but it does seem less likely. And I would say particularly when class sizes are small and when people are following public health recommendations. I would say this is one area where I'd like to see more data before I'm really confident in these findings. But thankfully, and neither Dr. Mani and I work with kids regularly, but relatively few children with COVID end up being hospitalized compared to adults. The symptoms tend to be pretty similar, but often more mild. And then I'll also say, as many of you may have heard in the news, there is an interesting condition called multisystem inflammatory syndrome in children, or MIS-C, which is really kind of an abnormal immune response leading to lots of inflammation in multiple organ systems. That's one way that, it's rare, but it is a different manifestation of COVID compared to what we see in adults. But otherwise, we are, quite thankful that children seem to be a little bit less able to transmit COVID than adults do.
And this kind of segues nicely, you brought up school and spread and transmission. And although you mentioned we don't have a lot of data or information on that yet, I think some people were interested in the idea of what we could do in the future to make classrooms more safe, or ways in which we could disinfect them from that sense. Do you have any idea or any thoughts on what that process would look like?
Yeah, it's a complicated topic. I know that one of the registrants or participants asked about UVC, which is basically UV light technology. That's something that we actually use in the hospital, not uncommonly. UV light is well known to break down viral particles, and we actually have robots at UWMC that we use to clean patient rooms, not just rooms with COVID. We use them to clean a lot of different rooms. Technologies like that can be useful in schools and other places, but I really think the main issues in schools are what is the community incidence? Can the kids and the teacher be masked? Can they be distanced? And really, how is the building ventilated? And I think by the time you start talking about other adjunctive expensive technologies, I really worry about whether the basics are actually in place or not. I do think schools in general should probably be the last things to close and the first to reopen, and bars should probably be the first to close. And of course, that's just my my personal opinion. But we know how important early childhood education is for for child development. So I think at some point it can be done safely, though particularly here in Seattle, I am very concerned about how high our incidence is and the rates of that going up. And so I think, right now, I do think that, the governor and the county are doing the right things in terms of, their directives to schools.
Thank you so much for that insight. I think along the lines of disinfecting and sanitizer, as we saw when COVID first started, all of these things went off the shelf and we ran out, and people were kind of wiping down every counter in every area, which was obviously appropriate at that time. But what is some of the evidence kind of surrounding contracting COVID from services like doorknobs or gas pumps? What are your thoughts around that type of transmission, Dr. Cohen?
Yeah, I'm happy to take this one, and then I can turn it over to Dr. Mani. The role of what we call environmental transmission, which is when you touch something and then potentially inoculate yourself through your eyes, your nose, your mouth. That the environmental transmission role has been really heavily debated. There is no question that COVID or SARS-CoV-2, which is the virus that causes COVID, can persist on surfaces for a long period of time. I think the question in my mind is whether it actually persists in sufficient quantities to pose a threat. It's been interesting. The CDC has really downgraded the role of environmental transmission, and really emphasized the role of person-to-person spread through respiratory particles. And I think environmental transmission can happen in heavily contaminated areas like hospital rooms or somebody's residential area. But when I'm out in the community and I'm thinking about pumping gas or touching something else in the environment, I just bring my hand sanitizer with me, pump my gas, wash my hands, and then I really don't give it another thought.
Thank you. Similarly, people are wondering, obviously now with the movement and the shutdown, we are limited to outside activities. Even with that, Dr. Mani, how safe is it to be outside, maybe doing some of this outdoor dining, these outdoor breweries at this time?
This is a really challenging question. I think as our community prevalence rises, all of these activities become increasingly more risky. They are riskier than they were during earlier periods of the year when our case numbers were lower. So I think if you're talking about going to a brewery with friends, it all depends on who you're with, who you've been around, and who they've been around. And it's a really difficult risk calculus to make. I will say that among our infection prevention group and among our infectious diseases group, I don't think any of us have been doing any kind of dining at restaurants, even if it is outdoors, because that risk is just too hard to judge. So personally, I would say that sitting across the table from someone at a brewery, even if it's outdoors, is not distance enough to mitigate the spread of COVID if one member of the party was infected. personally think it would be great to support your local brewery or your restaurant by getting food and drink to go, taking it to a backyard or a park, or somewhere else where you can really be distanced in order to mitigate potential spread of infection.
Thank you. And just again, reminder to everyone in the audience there, if you guys have any other questions that you want as we go through this, please feel free to put them in the Q&A. And it may take us time to get to them, but we would love to hear from you and really answer what we can to kind of put you at ease, or at least get some of your curiosities answered, okay?
Can I ask a question, Dr. Mani? I know just with the holidays coming up, I think one of the challenges that people are trying to figure out is, how to get together safely with folks. And I know that you actually got married recently. Is that right? What did you end up doing about your wedding?
Yeah, so there also was a question that came in about this, which was great. I had a 200-person wedding planned for May of this year that I unfortunately had to cancel, and made a lot of challenging decisions back in the spring about potentially how to mitigate risk and still carry out the event, but ultimately decided that it just I wouldn't be able to safely have kind of any version of the wedding that we had initially planned. So we ended up having a small, tiny wedding of 7 people back in September, which we were able to do safely and felt really good about doing. And so I think, it's really hard to know when these larger events we'll be able to safely do them, but it's hard to imagine a scenario where we can safely have events of greater than 100 people without a vaccine that has been widely distributed and is really effective.
Dr. Hussein, are you seeing your family at all?
I am not. So my family is in Florida, and unfortunately, Florida tends to have one of the higher rates of infection incidents and not as many of the protocols that we have in place in Washington. And so I think for the safety of all of us, my dad is over 70 right now, and my mom is in her late 50s. So overall, I think we're just trying to be safe. And instead of having all of us coming in from different parts of the country, we're just going to kind of stay at home and do a distance. It will probably be the first holiday that I actually miss, because it's about the only time of year that I see my family. Because as we all know, traveling from the West Coast to the East Coast is a day and a half in itself. And it's hard to get that time. So especially with the fact that there are a lot of layovers on your way down to that area, it kind of makes it difficult and very challenging. So I will not be going anywhere, but I will see them, virtually.
Yeah, sounds good.
And I actually think along those lines, someone had asked, if they are traveling or they do need to fly, do we have any best practices or advice for them? If you want to take this one, Dr. Mani.
Yeah, so I think the best answer would be to not fly or travel at all at this time, but we know that an abstinence-only message here will likely be ignored. So I think we do need to give folks the tools that they need to mitigate their risk, and people do want to see their families in a safe way if it's possible this holiday season. So personally, I have not flown since the pandemic began. I've had multiple trips that I intended to take, but then subsequently canceled last minute as cases rose prior to each trip. I think the best thing you can do is isolate for 14 days if possible, leading up to your trip, potentially also in conjunction with a test. And then on the plane itself, maintaining, wearing your mask the entire time that you're on the flight, really trying to minimize times where you're taking off your mask to eat and drink, and then being cautious on the other end. I think if we do travel this holiday season, given the fact that community prevalence is rising really across the whole country, we also need to have a plan in place, quarantine plan in place in case you do develop symptoms at your destination, which I think is a real possibility right now. So I think, with all of this in play, it makes travel much more challenging. And I think we all should be reevaluating our plans and really limiting travel to just those essential trips that we absolutely need to take.
Can I piggyback on that for a minute? I think the other question that a lot of my patients are asking me is, what's the role of testing before I go on a trip? And I think that's a complicated one to answer. I think what we don't want in public health is for people to get a test and then feel like that somehow gives them permission to travel safely, because a test is, as we know, is a snapshot in time, and it really just reflects on whether, I think a better way to phrase it is, the only way to really be sure that you're negative when you're going to interact with your family is if you've really been isolating for 14 days at least. So a negative test feels reassuring. It sort of feels like a safety blanket, but actually it's not really predictive of whether you're going to turn positive in the next few days or not.
Exactly. If I got a negative test today and plan to travel tomorrow, but in the last 2 days I was exposed to COVID, my test might not turn positive for 4 or 5 more days. And while that scenario might seem unlikely, it's actually one that we encounter quite frequently. It's just the testing is imperfect. So I agree, testing does not replace quarantine. Quarantine is superior to testing.
And then a couple of questions that have come in, in regards to if you're planning on not seeing other people and kind of staying home for Thanksgiving and celebrating the holidays on your own, is it safe to pick up, say, an item or two or a meal from a friend who's kind of cooking? And how would that practice look? And if people weren't wearing masks while they were cooking, is that something people should be concerned about? What are our thoughts on that, Dr. Cohen?
Yeah, I think those are all really timely questions. And I think, I see there's a question about what about wiping down groceries and just sort of, how to interact with others in the community. I think, again, the role of spread through environmental surfaces is probably pretty negligible. It doesn't, I think it's incredibly important to wash your hands. And I think, the rule in our household is if you touch anything that's outside of the house, you get to wash your hands. So, when we bring in the groceries, we, bring in the bags, wash your hands. I certainly, I'm washing my hands when I check out from the grocery store. And I would say similarly, if somebody wants to, drop off a care package or something like that in a distanced fashion, you just wash your hands after you touch it. But it, I would think it'd be very safe to eat. And we have not seen cases of, COVID transmitted by food in particular.
Great, thank you. And then along these lines of kind of what is safe and how to do things safely, a lot of the population or a lot of people have family members that are elderly or may otherwise have a compromised immune system. Are there some thoughts on what the safest way of interacting with those people are if we need to, and also their risk of kind of going to do the grocery shopping or getting their hair done, and what our thoughts are in that population specifically?
Sure, I'm happy to take this one. So I think, a lot of the messages that we've already been communicating sort of apply to this situation as well, that if you do plan to visit an elderly family member or someone who's immune compromised, I think quarantining before you visit them is really the best way to ensure that you are not incubating virus or, in that pre-symptomatic period where you're about to develop infection. With regard to whether those folks are safe to go to the grocery store and kind of do their regular activities, as we've discussed, I think those are relatively lower risk scenarios, going to the grocery store, going to the doctor's office, as opposed to social gatherings with other individuals where you're spending prolonged periods of time unmasked. Those are really the highest risk activities, the exact type of activities that all of us would like to be engaging in this holiday season. So I will say my family lives on the East Coast. My mom is in her late 60s, and I had a couple of trips planned to go out to visit her that I've canceled. And ultimately, I just decided that even if I obtained a negative test prior to getting onto a plane, I just couldn't be quite sure that I was truly negative, and I really didn't want to go there and infect her. And I work in a job where I'm not able to quarantine for 14 days. I can't stay at home and really be 100% certain that I haven't been exposed. So that was kind of the risk calculus that I took in that scenario.
And along those lines of kind of communicating with family and doing that risk-benefit measurement, during the holidays, there's always a lot of conversations that go and a lot of debating that goes between families when you finally see them. And I think some of the audience is concerned about the questions that people get in relation to masks and how we have been sort of divided in ways about mask utilization and how that important practice is. Do you guys have any helpful hints from talking to patients or family members about how to really go about that conversation in a, respectful way and an informative way that can be helpful to some of our holiday travelers and families? And sorry, Dr. Cohen, would you like to take a stab at that?
I'd be interested to hear Dr. Mani's take as well. I don't know if I have any great pro tips on this other than, we certainly see a lot of people wearing their masks in a manner that's not ideal. A lot of people kind of have they're doing the nose creeping out, or, you sort of see people wearing it on their chin, or, it's just not covering their mouth. And so the best way to wear a mask is just making sure that it is fitting as tight as possible, across your nose and covering your chin at the same time. And if you feel like you don't have a mask that does that, I think you probably need to get another mask. But otherwise, I would say, the actions around the holidays and, risk in the community in general, it's the best way I've heard it described is it's not like a light switch. It's not just on or off, right? It's a dial. And so right now we're really dialing back on the amount of risk that I think all of us, are feeling like we can actually take at this time when we go out. And so, yes, you want to get the masking right, but making sure that, outdoors is better than indoors. Even though my family doesn't live that far away from me, I do have elderly parents, and we are not seeing them indoors at all. This is all outdoors. We may go for walks, but even when we're walking, we're still wearing masks. So I don't know if others have tips on, getting people to wear their masks correctly.
I have asked people in public and in other places to please wear their masks correctly. I have felt empowered to do that. And, I think all of us should also feel empowered to do that. This is really, our success in this pandemic is really dependent on the collective will here. And so, yes, I agree. We really need everybody to buy in order to make some progress here.
And then some other folks were also kind of asking questions regarding Governor Inslee's recent policy change about all of us, kind of staying indoors and avoiding those indoor gatherings if we can. Can you guys speak to a little about, and I think you kind of touched on this, the idea about that 7-day quarantine and the ability to have kind of household gatherings? And Dr. Cohen, if you'd like to take a stab at it first.
Yeah, that's an interesting, it's an interesting point. And I think the public health world is probably a little bit divided on this. We absolutely favor harm reduction, in any public health measure. And I think, getting the message out to people in our community that we do need to isolate in advance of a trip, and having a negative test, does help a little bit. It does decrease the chances that you are currently infected, but it's not 100%. And so again, I think if you really want to particularly if you're visiting somebody who is very high risk, an elderly family member, somebody who's immunocompromised, somebody who has cancer, somebody who's receiving a medication that could suppress their immune system, I still worry about isolating for just 7 days and getting a negative test. And so, it's not a strategy that I've taken with my own family yet. And I think, just with everything going on, we also worry about exposures at the airport, or exposures at your destination, or when you come back. So unfortunately, none of this is foolproof.
Yeah, I agree. I think that if you can't quarantine for 14 days, then quarantining for 7 and having a test is certainly better than just quarantining for 7. But you do still run the risk of incubating virus. I think the other tricky thing is that, while we do have a lot of tests in Seattle, I think we run the risk of having more limited testing available to symptomatic individuals when we have a lot of people that are wanting to test who are asymptomatic prior to doing potentially risky things. So just keeping that in mind, that we really want to make sure that testing is available most rapidly or most available for those who are symptomatic and need to be tested sooner rather than later.
And that actually brings up a good point. I think a couple of people were wondering, we are recommending, getting tested if possible. Are there sites or areas that you guys recommend that people can go, or a website maybe that they can refer to figure out where the easiest and simplest way to test is? Dr. Cohen, you spoke up a little bit about this prior.
Yeah, I think we're really fortunate in the Seattle-King County area that we do have a lot of testing available. It's still, and I think as a country, we still do not have the testing capacity that we should have, over 9 months into this pandemic. But there are, a number of different sites here. UW Medicine has a site where you can get tested, usually pretty quickly. I will say that, we do try to prioritize testing, particularly for patients who are undergoing procedures, for patients who are symptomatic. I think, for people who just want to check their status, unfortunately, we're not quite at a point yet where we have, rapid testing that's available, though we're hoping that these types of diagnostics, what we call point of care diagnostics, will become more common over the next few months. There are a number of public sites that are run by the county, and you can find the information about those on the King County website. And they've got very easy self-scheduling, and then you can get a little QR code link. And I'm sure many of the participants who are listening now have done that. But that's a great way, particularly if you want a pre-travel test. They probably have more ability than UW Medicine, for instance, or your other healthcare systems to get tested. But if you have symptoms, we absolutely want you to get tested, in a system that where your provider works, or if you are not a UW Medicine patient but just want to sign up for testing, we can easily register you on the phone, because we do think it's important for you to know your status.
Thank you for that information. Getting back to kind of what we can do for prevention and harm reduction in regards to masks. A lot of the times, obviously, masks have been required inside anywhere in Washington. Is there a recommendation now, while people are outside either running or walking with household members, to still wear a mask and to practice that social distancing as well? And if so, are we still saying the 6 feet, or has any of that changed recently? And Dr. Mani, why don't you go ahead and take that first?
These are tricky questions where, again, it's all about risk mitigation. And again, as our community prevalence goes up, it becomes, sort of increasingly likely that someone that you're with may actually be infected with COVID. And, this virus really preys on any gap that exists. Yeah, I think that I personally have not, when I walk around in my neighborhood, and it's just myself or just me and my husband, I don't wear a mask when it's just the two of us, but I usually carry one with me just in case I, come into close contact with someone unexpectedly. I do think that being outdoors where the ventilation is, of course, much better is a much safer situation than being inside. And so I do not wear a mask when I am outside, but I do maintain distance even when I'm outside.
I completely agree. I went for a nice long trail run in Discovery Park this past weekend. And, if you go at a time when people are not out, I think, you probably do not need to cover your face. But I also think, there's something about creating a culture here in Seattle where people, feel empowered to wear masks and that they feel like it's the norm. And so, I've always got my mask ready. And if I'm, even going to be passing somebody, I will always, pull it up on my face for, leading up to when I'm passing them, and then take it off, after we're a safe distance away.
Thank you guys both so much for that. I think we covered a lot of these transmission questions and how to be safe and the best way to go about this during the holidays. I think some folks also had some questions out there about maybe briefly, if you can touch on this, Dr. Cohen, any new symptomatic treatments for our COVID patients that we are seeing, or stuff that we have seen that has been helpful in the hospital and in the outpatient setting as well.
Yeah, absolutely. And I'm also, Dr. Mani just came off service in the hot zone treating a number of, people who had COVID. And so she's, I'm curious to hear her thoughts. We have two main treatments for COVID right now for hospitalized patients. That's a steroid called dexamethasone, and then an IV antiviral medication called remdesivir. Those are really the mainstays of our treatment currently, in addition to supportive care with oxygenation, hydration, and really close monitoring while people are in the hospital. There's a new monoclonal antibody that was just approved for outpatient use. It's really challenging to think about how to implement it because it's IV, and you're thinking about bringing somebody who has COVID, who is likely contagious. This monoclonal antibody is most effective when it's given early in the disease. So these people probably are highly contagious. And we're thinking about bringing them into an outpatient healthcare setting to give them an infusion. So there are a lot of challenges, and I think people are struggling with what the niche is for that medication in particular. I do hope that there will be, there are many other investigational agents that are currently in trials, and I think we will, continue to learn more. I'm heartened that the, what we call the case fatality rate seems to be dropping a little bit. And I think part of that is we have learned how to care for patients better, but it's also that, younger patients are now getting infected and the demographics are changing. But Dr. Mani, are there any other treatments that I didn't mention that you want to cover?
No, that was great. Yeah, it feels really different right now treating hospitalized patients because we do have at least a couple of therapies that we have a little bit more data and information on compared to what things were like earlier in the pandemic, where it really felt like the Wild Wild West. We were trying lots of different experimental therapies and not really sure what was working and relying on data from very small trials. So I agree. I think we have a little bit more information when we are treating these patients, but we still need a lot more data, and a lot of the care still seems to be supportive. There seems to be a sweet spot where patients who are hospitalized can benefit from these treatments, but we still really don't have great treatments for patients who are very ill and hospitalized or critically ill ICU patients. They don't seem to benefit as much from some of the therapies that we have. So a lot more research going on currently.
Along the terms of that research, I know we had a large amount of questions kind of moving towards our next topic as far as looking forward into vaccines. This has been obviously very hot, and recently we've seen a lot of things in the news coming out about these possibly other 2 vaccines that look like they have some good evidence. And while the data is obviously not out on all of these, Dr. Cohen, do you think you could speak to the idea of these new vaccines and maybe provide some information or whatever it is that we know about them so far for our audience?
Yeah, I'm happy to do that. And, I know, Dr. Hussein, you've also been working on some of the clinical trials for vaccines. So, I'll also be interested to hear some of your thoughts. But isn't it great that we're talking about this? It just really, just the news of the trials coming out on Monday just really warmed my heart. There's several trials that just released interim results, and there are many others that will be out in the next few weeks to months. So, people probably know there's a Pfizer vaccine that is a 2-dose series, and they're given about 3 weeks apart. That, the interim analysis suggested that it had about 90% efficacy. Some of the downside to the vaccine are these, what we call the cold chain requirements. It really needs ultra cold storage. And the reason for that, the analogy that I heard that I really like is, these are new types of vaccines. It uses a technology called mRNA, which is a piece of genetic material that helps our body actually produce, viral-like particles that the immune system then recognizes. These viral particles are in no way infectious. They just induce our immune response. But this mRNA is very unstable. It's sort of like chocolate. And so if you keep it in your hand, it'll start to melt. And then they've put a shell around it, almost like an M&M shell that prevents it from melting in your hand. But it still is, is quite unstable, and so it needs to be kept in the freezer. There's another vaccine called the Moderna vaccine, also 2 doses. These are 4 weeks apart, and that's supposed to be about 94% efficacious. But the requirements in terms of the cold chain for that are less stringent. You can actually keep it in the fridge for some period of time rather than a freezer. But also just, stepping back, it is truly amazing. I mean, really a feat of, human achievement that, the Moderna sequences in particular were already being planned, in January and February of this year. Essentially as soon as we had a sequence for SARS-CoV-2, vaccinologists were already planning and, and strategizing how to build an effective vaccine. So I think the big questions on everybody's mind are, how durable or how long lasting are these immune responses going to be? We don't know. Thus far, we think the immune response is really good. And so I'm very optimistic about this. And then, these are interim analyses, right? So it's, reporting data in the middle of a study. That means we still need about 2 more months of follow-up to make sure that, there are no major safety concerns. And then, of course, there's, as people are alluding to in the chat, there are these huge, logistical challenges with allocating the vaccines and then implementing vaccination programs. So my hope is that, we, as healthcare workers, we may get something in our arms, as early as the spring of 2021, maybe a little earlier. And I think, for other populations at risk, it's possible that that's on a similar timeline. But I think for the general public, it's hard to know. And so it may be not until summer or even fall. And so vaccines are part of the exit strategy, but we still really need people to make sure that they're continuing to mask, continuing to distance, and really continuing to do all the other public health interventions that are so important to keep this virus contained, because we are still going to be dealing with this for many months, even after a vaccine is approved.
Thank you so much for that, Dr. Cohen. And, as you mentioned, from the clinical trial perspective, it's been interesting to just be in this time where really the community and the healthcare workers are trying to get together and work toward this common goal. I think some people have alluded to in the audience as well, and there's obviously some concerns that we've heard about the idea about vaccine being done so quickly, since it typically takes us so long to kind of come up with these things. And I think the idea out there is really that typically as different healthcare structures and different companies, we're always working on separate things and working on different diseases. But really in this global pandemic time, everyone's resources and time and thoughts have really been put into kind of one common goal to get a vaccine out there. And I think that is why we see so much of this integration and moving forward in a timeline that we typically aren't used to. So, if that's any reassurance for folks out there, it's not so much that corners are being cut, but more so all the resources and energy and everyone's minds are being put towards one common goal, which I think is really something that says a lot about, the world and people coming together to kind of work for a common cause. That being said, I know some people were very interested in vaccines and how they could become involved, and if Seattle themselves are doing any trials. And there are a couple of trials that are going on here and that will be starting up as well. And so if you are interested in participating or learning more, I recommend that you guys go to coronaviruspreventionnetwork.org. And we can try to put that link in the chat box if possible. But basically there you can kind of register for this large vaccine network and see what trials are in this area and go through that and see if you can participate and fit in the criteria to help. What I would like to point out is that, because coronavirus affects everybody and all types of people, what we would really like is for all types of people to be involved, right? In order for us to have evidence and data that helps the community, we would need the community to be represented in these trials as well. So, making sure we have a good variation in ethnicity and race and culture is helpful going forward so that we know that the results that we have are truly beneficial to those that this disease affects. Dr. Mani, anything you wanted to add on that vaccine front?
Nothing major. That was a great summary. I think we'll ultimately be in a situation where we have multiple vaccines available. That would be kind of the best case scenario. And there are multiple vaccines that are currently in phase 3 trials that we're hoping to learn more about once that data is released, hopefully later this year.
And then, Dr. Cohen, you mentioned how we still want people to practice safe distancing and masking and all that while we wait for a vaccine, and maybe even after, just until we have really good data and have some long-term effects. In lieu of vaccine being created, do you think that UW will mandate that people are required to be vaccinated? Or is that something that we do as an organization? Has been some people's question.
Yeah, it's a very good question. I think we're still grappling with some of those issues, but like every year with influenza vaccination, there's a very stringent process where we expect essentially 100% compliance with flu vaccination. There is a declination process if people truly have a medical contraindication, but similarly, we expect healthcare workers to be vaccinated to hepatitis B, to measles, mumps, rubella, and to chickenpox. And so just with the really really important threat of COVID to our staff and our patients, it's hard to imagine anything other than a very high bar for somebody not to get the COVID vaccine.
And I think back to kind of talking about these vaccines and these mandates, people are concerned about the safety of getting a vaccine, right? So early that's been developed. Dr. Cohen, can you speak a little bit to that and how we feel and how comfortable we are having people get vaccinated or at least participating in some of these trials?
Yeah, I mean, I think, first of all, if any of you are participating in these trials, thank you. This is, just an incredibly important time to be involved in science in any capacity. Yes, we are, very closely looking at the safety data. And I think even after a vaccine is reviewed, we will have our vaccine experts at UW Medicine review the safety data very, very closely and make sure that we are all comfortable, with the vaccine. I think none of us, I think that, the most important part of having a successful vaccine is not just having it approved by the FDA, but actually having people accept that it is an effective vaccine. And so we need to make sure that it's accepted in all sorts of diverse communities, and that, our healthcare workers feel comfortable getting it in their arms. So, I would say these results are encouraging, but, we still have not made any firm decisions on, which vaccine is the one to go with. And as Dr. Mani mentioned, there are still several others that are in clinical trials where we're, waiting results. But I would, just to reiterate, this is a process that will not be shortchanged. It's the development of the vaccine that's the warp speed. It's not, the warp speed is not getting through the safety data or taking shortcuts.
Thank you, guys. And I think, a good way to kind of help as we move towards the end and closing this up, just a few more questions. What would you say are some of the lessons that we've learned and maybe would be the most significant impact from COVID-19 in the long term, both positive and negative parts of that? Dr. Mani.
Sure. So I think, we have learned a lot since January, February, March. It feels like in COVID years, it's been about a decade. We know a lot more about what works and about what doesn't work. We know that masking works, that distancing works, that hand hygiene is important, that face-to-face interaction with other individuals over a prolonged period of time inside is a high-risk setting. I think knowledge is not enough. We do know a lot, but we also need the collective will of the people and political leaders to really support these interventions in order to really make a difference on a public health level. I think as far as, what are the negative and positive, potential impacts of this pandemic, I think the human toll is devastating, and it's the number one, in my opinion, negative impact that this pandemic has had. The economic devastation, will likely be long lasting, and the mental health of our collective society, I think, is really at a low place right now. And I am really hoping that things turn around in 2021 so that we can really make some progress there. On sort of the positive side of things, I think many of our communities are closer now than they ever have been. Within the UW system, we've formed partnerships across the hospital sites and are doing amazing high quality research at a faster pace than we've ever done before. And it's very inspiring to see that come together. It's amazing to see the healthcare workers doing incredible work on the front lines, taking care of these patients. And then I think this is also a positive. This pandemic has really brought to light the racial disparities that have always existed in our country. I think pandemics have always revealed a lot about what a society is like, and the fissures and the cracks have been exposed. And so we have a lot of opportunities there for progress going forward. So a lot of work to do to get to a better place, which hopefully will start now and continue in 2021.
And Dr. Cohen, anything to add to that? What are some of your thoughts?
Yeah, I completely agree. I think the mental health aspect for the general public as well as healthcare workers is incredibly important. I think, our healthcare system is sort of designed to deal with acute stress, but I think it's been very, very challenging. But, chronic stressors, particularly in healthcare, are much harder to deal with, both from an employer standpoint as well as, a patient standpoint. My hope is that in the long term, we'll be able to invest in a public health infrastructure. So we'll be more prepared for these pandemics that will, it's not sort of if, but when, right? We know that these, are continue to come, even though COVID is really an extreme example. I'll also say, the politicalization of simple public health measures like masking and social distancing has been extremely troubling, to say the least. And there's also just been a really frustrating co-epidemic of misinformation, which takes an incredible amount of resources that could be deployed in other ways. And so I hope that we as a community can find a way to commit to finding a few trusted sources and scientific communication. But I certainly echo Dr. Mani's comments about this is really unmasked, really tremendous racial disparities, which have always been present in our healthcare system. I do think on a positive level, it's been heartening to see more state and regional coordination as well as outreach to some of these marginalized communities that are really disproportionately impacted. But yeah, we have a lot of work to do before we get out of this.
Thank you guys so much for those thoughtful responses. I think as we wrap up here, maybe just some final words from each of you, what people can take away from this session, and maybe what you would say is important going forward, looking to the holidays, since that's what's on everyone's minds, and what you would say. Dr. Cohen, we can start with you.
You know, I would just say, be safe. Again, it's not, you know, think of it, risk as a dial, not a light switch. And, you know, really just, you know, using common sense. We know what works, and a lot of COVID is driven by all of our behavioral actions in the community, right? I mean, we all have the power to prevent spread if we sort of commit to, you know, basic public health measures. And I'll just say, you know, we really appreciate all of you tuning into this, to thinking about these, you know, issues, and you know, we are always open to your feedback on how, you know, we can improve public health messaging.
Absolutely. We appreciate all of you. And I agree, we are in control of where this pandemic will go. All of us, all of you, all of us together. And so I think we should acknowledge that and be as safe as we can going into this holiday season, acknowledging that we will need to find safe ways to be in small groups with each other in order to get through the holidays together.
Thank you guys so much, Dr. Mani and Dr. Cohen, for your time. And thank you guys for tuning in and for sending in those really insightful questions and helping kind of the community answer things as we go through all of this together as a unit. I think the session was recorded, and the link should be there in the chat box if you guys want to see it later and send it to those who you think might benefit from it. We appreciate that, and we thank you so much for your time, and thank you for coming today.
Thank you for having us.
One more thing, I think that there's also another webinar through the Whole U, and I believe that Tammy is going to post information about that right now in the chat.
It is there tomorrow.
Great.
Thank you guys so much for participating.
Thank you.